Benjamin Schwartz, National Association of County and City Health Officials.
Present.
Hannah Hinkle, National Rural Health Association. Eve Cooney, Organization for Safety, Asepsis, and Prevention. Karen Raven, Pediatric Infectious Disease Society. Maureen McGrath, Public Health Agency of Canada. Lisa McGifford, Patient Safety Action Network.
Present.
Hillary Babcock, Society of Healthcare Epidemiology of America.
Present.
Stephanie Taylor, Society of Hospital Medicine.
Hi, present.
Robert Sawyer, Surgical Infection Society. Tiffany Wixton, the Joint Commission.
Present.
We have met meeting and voting quorum. Thank you all for joining, and I'm going to pass it on to our DFO, Alex Cowan.
Great, thank you, Sydney. Wanted to welcome everyone to the November meeting of HICPAC. I just have a few quick announcements. First, I'd like to acknowledge a number of HICPAC members who will be retiring at the end of the year. First, Dr. Judy Guzman-Cottrell. Dr. Cottrell has been a member from 2019 through 2023 and has been really instrumental in the NHSN work group, including leading some incredible work on pediatric definitions, as well as our work here on the isolation precautions. Currently, she will be greatly missed and we wish her well. Also would like to offer a special note of thanks to Mohammed Faqih, Elaine Decker, and Joanne Reifsnyder. They had been extended through the end of this year and were acknowledged at the last meeting, and just wanted to reiterate that they will be officially retiring at the end of this year as well. Want to again offer special thanks to them. And I did want to introduce one new liaison, Dr. Aaron Epson. Dr. Epson is Medical Director and Chief of the Healthcare Associated Infection Program at the California Department of Public Health. She is board certified in internal medicine and infectious disease, and also completed medical epidemiology training as an epidemic intelligence service officer here at CDC. In a role at the California Department of Public Health HAI program, for the past 9 years, Dr. Epson is responsible for overseeing statewide and regional healthcare-associated infection and antimicrobial resistance prevention and response activities. In addition, at the national level, Dr. Epson serves as the Council of State and Territorial Epidemiology Representative and Governance Committee Co-Chair of CORA, or the Council for Outbreak Response, Healthcare-Associated Infections and Antimicrobial Resistance. And in this capacity, she has led the development and updating of COVID-19 healthcare outbreak investigation and reporting thresholds, in addition to multiple other CORA products. So welcome to Dr. Epson, who will be representing CSTE. With that, let me turn it over to our interim chair, Dr. Sharon Wright. Sharon.
Thank you, Alex, for those updates. Let's move on to today's presentations. I'd like to turn it over to Dr. Michael Bell for an update from the Division of Healthcare Quality and Promotion.
Thank you. Good morning, everybody. Welcome. First, my appreciation for those of you that traveled today. Great to see you in person. For those of you that are making time remotely, thank you as well. We hope to see our members and liaisons in person next time. I've got two things to update you about for the division today. The first is related to long-term care. Just a major thank you to the many long-term care partners and technical leads who have made it possible for the past several years and currently are working to ensure that long-term care populations are well protected. Currently, the work has been related to ensuring that with the respiratory season upon us, long-term care populations are able to gain access to and have receipt of, that is administration of, vaccines should they desire to be immunized. That work has been very important to make sure that there isn't a gap that we can prevent. So a big thank you to the organizations that represent both the long-term care facilities, the long-term care providers, and the actual frontline long-term care staff themselves. The second thing that I wanted to flag is related to data. The National Healthcare Safety Network is one of our premier data systems for healthcare related issues. It is something that grew thanks to our partnership with and support from the Centers for Medicare and Medicaid Services. We have over 5,000 acute care hospitals that use NHSN, and that jumped to an even larger number courtesy of the pandemic. Because of a need to have visibility into long-term care spaces, understanding whether residents in long-term care facilities were being harmed disproportionately, and so on, we were tasked with extending NHSN to the roughly 15 or 16,000 nursing homes around the country. That work was undertaken very rapidly and allowed us to understand what was going on there. As you know, with the end of the public health emergency, some of our data authorities have shifted. And so we're currently in the process of making sure that we go through and flag what we need to retain and find ways to do that, as well as understand how we can progressively reduce the burden of data collection and submission on all of the participating facilities. We're extremely sensitive to the fact that, especially in long-term care, staffing is limited. There often are not dedicated individuals for collecting or submitting data. The picture there is very lean compared to what we often rely on in acute care facilities. So with that in mind, we are continuing to press forward to identify automatable, machine collectible type data elements. So this is a combination of reassessing metrics where we can, but also working closely with the health informatics world and the electronic health record companies to make sure that where there is an opportunity to streamline and automate, we take the best advantage of that. Behind the scenes in all of that, a nod to our staff who do the work to make sure that whatever we switch to is still valid and still measures what we think it's measuring, and can continue to be used to drive progress and reduction in bad outcomes. So I'm going to stop there. Those are the two updates for today, and thank you again.
Thank you, Dr. Bell. We are now going to move over to the first presentation, which is the isolation precautions guideline work group update. I'll turn it over to my work group co-chair, Dr. Michael Lin, to start us off.
Okay, great. Thank you for the opportunity on behalf of the Isolation Precautions Work Group to present the draft guidelines. First, a disclaimer. The findings and conclusions herein are draft have not been formally disseminated by the Centers for Disease Control and Prevention and should not be construed to represent any agency determination or policy. I'd like to acknowledge the isolation precautions guideline work group members, including Sharon Wright, the co-chair, Hillary Babcock, Elaine Decker, Judith Guzman-Cottrell, Anurag Malani, Joanne Reifschneider, Mark Rusi, Connie Steed, Julie Trevetti, and Deborah Yakoa. I also like to acknowledge CDC support, including Mike Bell and the many members of the CDC, DHQP, and NIOSH technical staff that you see listed here, as well as the CDC DHQP support staff. And I'd also like to acknowledge feedback that we received from the HICPAC long-term care work group and experts from NIOSH and external organizations. So for our agenda today, we are going to go through an overview first, and then we'll dive right into a review of part 1 of draft guideline and recommendations with discussion for section A, overview of transmission of infectious agents, section B, fundamental elements needed to prevent transmission of infectious agents in healthcare settings, and C, precautions to prevent transmission of infectious agents. As an overview, today we present the first draft, and specifically part 1 of an update to the 2007 Isolation Precautions Guidelines to HICPAC for consideration. Portions of this 2-day meeting will be dedicated to detailed discussion and review of the guidelines. If ready, HICPAC members will vote at the conclusion of this 2-day meeting on whether the draft guideline is ready for CDC review, followed by a 60-day public comment period by a Federal Register. Comments received during the 60-day public review period will inform draft guideline revision by HICPAC and CDC, which will occur before any future HICPAC consideration of the draft guideline for a final meeting discussion and vote in 2024. I'd like to start off with 3 key points from the 2024 guideline. The draft 2024 guideline updates the conceptual framework for pathogen transmission, including the recognition of a continuum of pathogen transmission by air, rather than an outdated dichotomy of droplet versus airborne transmission. It proposes new categories for transmission-based precautions, including a new category for transmission through the air called special air precautions, which is expected to increase the use of NIOSH-approved, fit-tested N95 or higher level respirators during responses to pandemic or emerging respiratory viruses. The 2024 guideline does not provide any pathogen-specific guidance. Pathogen-specific guidance will be addressed in a future part 2. The work group goal is creation of an update to the 2007 Isolation Precautions Guideline. The draft guideline is intended to replace corresponding content in the 2007 guideline. Elements of the 2007 guideline that are not directly affected by this update, including the 2007 guidelines Appendix A, will remain active until updated specifically. The update is meant to be clearer with more concise language and formatting. Recommendations largely address infection prevention strategies that frontline healthcare personnel may implement at the point of care. And the guideline is intended to be applicable to all healthcare settings. This schematic shows the relation between the components of the 2007 guideline and the 2024 update. Parts 1 through 4 of the 2007 guideline are now combined into a single part 1 that we are reviewing today. This part 1 is pathogen agnostic. The 2007 guidelines Appendix A will eventually be replaced by the part 2 of the 2024 guideline. And this will be pathogen specific and represents future HICPAC work. This slide shows the general outline of the 2024 guideline, highlighting certain sections containing recommendations that are in red and with asterisks. During this presentation, slides with recommendations will be clearly labeled in the title. Now we'll review key sections for Section A, overview of transmission of infectious agents. Factors affecting transmissibility. Transmission occurs when an at-risk person acquires a pathogen from an infectious person. Transmission is determined by pathogen, environmental, and person factors at the time of event. While pathogen factors are often biologically intrinsic, for example, the ability of a pathogen to remain viable during transit, environmental and person-specific factors may vary by location and over time. Environmental variables include air, for example, temperature, humidity, ventilation, and surface, for example, material porosity conditions. Factors that vary among infectious persons include pathogen load and shedding rate. Factors that vary among at-risk persons include host defense mechanisms that are non-immune based, for example, intact skin, and immune-based, for example, pathogen-specific immunity from prior infection or vaccination. Significance of transmission. Transmission can result in colonization or infection. Based on the health impact that a pathogen is expected to have on an individual or the community, some pathogens are recognized as requiring intensive efforts to prevent transmission, while others may not rise to that level. Less intensive effort might be indicated when outcomes are not usually severe, the population has a high degree of immunity, and effective therapeutics and vaccines are available. The boundaries describing those categories require risk assessment and can vary by setting and population at risk. Transmission pathways. In the healthcare setting, pathogen transmission pathways can be grouped into two broad categories: pathogens that spread via the air and pathogens that spread via touch. Pathogens generally spread via a major pathway. The multiple pathways might contribute to spread. Pathogen transmission epidemiology is informed by observing patterns of infection spread. Transmission via air. Pathogens can transmit via air over short distances through direct splash or spray of the pathogen onto a part of the body. For example, spray from a sneeze landing on a person's eyes or mouth, or variably across ranges of distance and time via suspended infectious particles. Pathogens suspended in the air cause infection via inhalation and deposition along the respiratory tract, anywhere from the nasal or oral passages to the lungs. Historically, the infection prevention community has categorized transmission of respiratory pathogens as droplet or airborne. While these epidemiologic terms reflect observed patterns of short versus long distance transmission respectively, the terms do not explicitly describe a continuum of respiratory pathogen transmission through the air. Pathogens that spread via the air preferentially transmit over short distances due to greater concentrations of infectious particles in the air near an infectious person. However, each pathogen has a signature pattern of observed transmission that extends variably across short to long distances and over time, reflecting unique characteristics such as pathogen viability while suspended in the air and the required dose for causing an infection in a susceptible person. Pathogens that remain infectious for a long time while suspended in the air, for example, Mycobacterium tuberculosis, measles virus, and varicella virus, are capable of causing infections over long distances, such as across a large part of a building or healthcare facility. Transmission via touch. Transmission via touch occurs through physical contact with the pathogen. Transmission in healthcare settings can occur via intact skin, non-intact skin, including percutaneous routes, such as needle stick injury, or mucous membranes of the face and gastrointestinal tract. Transmission by touch can involve intermediary reservoirs, such as people, surfaces, or equipment that facilitate spread. Approach to transmission-based precaution recommendations. Recommendations for transmission-based precautions are based on evaluation of clinical epidemiologic studies in healthcare settings. Evidence reviews in this guideline focus on clinical studies with infection outcomes because such studies compare prevention strategies in the context of feasibility, user adherence, and implementation within a hierarchy of controls. For example, engineering, administrative, and personal protective equipment controls available in the healthcare setting to reduce risk of infection. The methodology and evidence reviews informing recommendations in this guideline are available in this guideline's appendix. Recommendations in this guideline largely address infection prevention strategies available to frontline healthcare personnel at the point of care. And now we'll pause for discussion for section A.
Thanks, Mike. Does anyone, any of the HICPAC members have questions or discussion points for section A? Dr. Shinoy.
Thank you. And thank you so much to the working group and the chairs for excellent work. I have a few general questions about this part of the guideline. One is whether or not it would make sense to include a section that describes topics that are deferred to other existing guidelines or other existing guidelines. So for example, the things that will not be covered in the guideline or deferred to others. I think that could be helpful for those who want to refer to those. And there are particular parts later on that I'll highlight that I think could go there, but that's just as a general intro section. The other part is the use of the term point of care versus point of use. It starts off in this section, the point of use or point of care. And I'm wondering throughout if you might think about it as point of use, because some of these interventions are not actually done in the point of care, but and by individuals who are not delivering care. So it just might make sense to consider that. And then later on in the guideline, there'll be descriptions of recommendations as standard or expert opinion. And so it may be helpful in this introduction section to describe what is meant by standard practice versus expert opinion. And then the last piece I will get to later on, but thank you very much.
Thank you. Dr. Weber.
A great job on this. Thank you for all this hard work. You mentioned under air the importance of inoculating dose. I think that should probably be mentioned higher up under factors that affect transmissibility, because that's true for all pathogens, particularly for fecal oral gastrointestinal pathogens. So the low inoculum ones like norovirus, we worry about person-to-person transmission like a playroom for children. The higher ones such as salmonella, food and waterborne, but less personal transmission. So I think I'd move up that statement about the importance of the inoculating dose to be more general, not just for air. Thank you.
Thank you. Other comments?
I had one last one. In the beginning, we talked about healthcare settings. Does it make sense to define exactly which healthcare settings this will apply to? Is it all healthcare settings, acute care, healthcare delivered in home care, those sorts of things? That was one question.
Thank you. The intent is to apply to all healthcare settings. Sydney, I can't see if are any HICPAC members or liaisons online who have comments. Thank you. Any final comments, or we can move on to the next section? Okay, why don't we move on to section B? Section B is the section. Oh, you have one more. I'm sorry, there's one more.
So I have a couple more slides before we get to section B, and this is actually taken from the appendix, but I think we'll answer Dr. Shinoy's question about standard practice versus expert opinion and how some of these recommendations are formulated. So again, this is a recommendation and formulation of categorization that's currently existing in the appendix of the draft guideline. And I'm sorry, I'm in trouble advancing, so bear with me for a moment. Maybe if Laura, you can advance the slide for me, I'll just give you next slide. While we're waiting, I just want to clarify too that when we talk about appendix today, there is an appendix A from the 2007 guideline. And if we refer to that, that'll be appendix A, or in the written draft guideline, it'll be referred to as the 2007 guideline appendix. For what we are talking about here, this is the appendix from the draft guideline. And I think what I'll do is while we're waiting for the slides, I'll just go ahead and read through the text that I've chosen to highlight here from the appendix. So for the recommendation formulation, the authors conducted a thorough review of the recommendations contained in the 2007 guideline. This review identified recommendations from the 2007 guideline that remain relevant in 2023. These recommendations